All right, here we go. Once again, it is gastrointestinal pathology today. It is week 4. It is not all 3. I should have changed that. I'll change that on your slides. But it is, did I not get my marker out? It is part 1. Part 1 of 2. We'll break this up into 2 lectures today, so it's not all of them. All right, here we go. So let's talk about Zenker diverticulum. We've been talking about the esophagus. We're actually going to finish the esophagus today. Also known as the pharyngeal pouch, a hypopharyngeal diverticulum, pharyngeal esophageal diverticulum. But I think for boards it's going to say Zenker's diverticulum. It is a diverticulum, so that's an outpouching of a tube, like the appendix is a diverticulum. And remember, the polyp is the opposite of a polyp, is an inward growth, which is not hollow. A diverticulum is hollow. It's an outward growth extension of a tube. And yeah, it's a pathological herniation or outpouching of the posterior lateral part of the upper esophagus. Specifically, it occurs in a very controversial, kind of like the area of anatomy around the umbilicus. Same kind of deal here. In an area called Killian's triangle, which is a terrible word because it's not a triangle, it's a dehiscence. But it's the meeting of 2 embryological muscle layers, as we'll see. So very complicated piece of anatomy. It is controversial. Some authors say that it occurs between the meeting of the 2 components of the pharyngeal or inferior pharyngeal constrictors, and we all know what those are. That's not controversial. There's cricopharyngeus and thyropharyngeus. But it's actually not that. Standring and other board authors say correctly that it's a meeting between the 2 subcomponents of the cricopharyngeus muscle. You remember from Gross 2 days, cricopharyngeus has 2 components, the oblique portion and the transverse portion. The oblique portion also is known as pars oblique portion. That's easy, but transverse portion has another name. It's called pars fundiformis portion. Let's look at a picture. So here's the eyeball of this person. There's the nose. There's the mouth is right there. There's the ear. So we're looking at the side here, side view. So here's the thyroid cartilage, the lamina of the thyroid cartilage. Here's the cricoid cartilage right here. And so the inferior pharyngeal constrictor has 2 components. Thyropharyngeus, where the fibers attach into the thyroid cartilage, and cricopharyngeus, where the fibers connect into the cricoid cartilage. But specifically, Killian's triangle, Killian's dehiscence, is the area right here. It's between the oblique portion and the horizontal portion of cricopharyngeus. Everybody understand that? Got that? All right. And yeah, the connection between the oblique and transverse fibers, that's it. It's not super strong, and embryologically it just never developed super strong in humans, and it's a weak spot. And you can get, here's kind of the junction of those 2 sets of fibers, especially if they get really stiff and fibrotic as you age. If the pressure goes up during swallowing, you can start to slowly rip them out, and it bulges out further and further and further, and that is a Zenker's diverticulum. Okay, stomach would be down here, the mouth would be here. Right, so that's kind of there's your ear again, and drawing skills are not great. But yeah, so that's what it is. And you can see that it's going to collect fluid, and when you swallow, some water can go down here, or milk could go down here, or soda, or beer, food particles, and flat out food can get stuck down here, so you can cause all kinds of trouble. There's just another picture of the horizontal and oblique portions of in the cricopharyngeus muscle, and you can see it's herniated out. Okay, how do you diagnose this? Well, it's part of an upper GI study is ordered, and part of that study is a barium swallow. So you have the patient take several sips, gulps of barium under fluoroscopy and see if you can catch something. And sure enough, this patient took a barium swallow, and the barium has passed, but you can see after several swallows it's collecting right here. So that is our Zenker's diverticulum. Oops. Yep. Sometimes you can palpate between the lamina of the thyroid cartilage and the SCM. Sometimes you can actually feel, if you shake that area, you can feel like a little liquid gurgling beneath your fingers. That's actually called a Boyce's sign. And so sometimes there is a palpable sign for Zenker's diverticulum. It's considered acquired. You're not born with it. So, and it usually doesn't progress. It can kind of get one size and stay that way, but it can. I mean, it doesn't. The rule of thumb is it doesn't once it forms, but it certainly can. It has a tendency to favor the back, but the left side, kind of the left lateral portion of the neck, it can come out kind of sideways. Usually it's straight back though, but because of the spine, it kind of squirts to one side or the other if it gets big enough. Usually the left. The prevalence of this has been estimated at about 0.06% of the population. Not super common, rare, but much rarer than, or much more common than Marfan syndrome. Usually shows up in the 7th and 8th decade of life, which is the 60s and 70s. Is that right? Second decade of life is teenage years. Yeah, so it's always down one, so 60s and 70s. Men seem to have a problem more than women compared to this condition. I mean, here's the emblem in my mind. I always remember these. The oblique portion of cricopharyngeus. This is the Rolling Stones, right? Their emblem. And then here's the transverse portion stretched out. And there's the diverticulum. There's the Zenker's diverticulum poking out through this Killian's dehiscence, which turned into Killian's triangle, because now it looks like a triangle, like two triangles if we drew one like this. It's kind of forms into a triangle after the herniation occurs. But yeah, it's the old Rolling Stones. They're still out there jamming, maybe not as good as they used to be, but nevertheless, they look like they're having fun. And there's the classic presentation with the spine removed. So it would be pushed, the spine would be pushing it to the left usually. There's a barium swallow showing it as well. What about risk factors? Well, the chronic inflammatory muscle diseases like polymyositis, dermatomyositis, they can do this. Or any other of the fibrotic diseases, if the cricopharyngeus muscle starts to get stiff and infiltrated with fibroblasts and scar tissue, and it's stiff, when you swallow it doesn't have any spring or give to it, and it can rip. So that's kind of thought to be the cause of this fibrosis. You know, that, and of course, when you swallow, if it has no give, it creates really high pressure in the esophagus, and it can push right through it. So therefore, the esophageal dysmotility disorders that we study, like nutcracker esophagus, if you happen to have one of those, especially if they affect more the proximal part of the esophagus, that can also increase the risk because you have peristalsis of the esophagus that's way too strong. What are the symptoms? Well, it's kind of hard to tell apart from other things except for one. Dysphagia, adenophagia, trouble swallowing, pain, flat-out pain, just difficulty in bothering, frequent burping up and regurgitation. That little pocket may catch fluid and that may come into your mouth. Here's a different one, though. Really terrible. I mean, everybody's probably got a little bad breath now and then, but really rotten breath. is a sign of this. It could be tooth decay and things like that as well too. And these patients, they are at risk if they have liquid coming up unexpectedly from this little pouch and it's close to the larynx, the opening for the larynx. They can start choking and aspirating this nasty bacterial infilled fluid that comes out of the diverticulum, and they can get pneumonia. Could get a bacterial pneumonia, which is called aspiration pneumonia if it's from kind of burping up and swallowing it. Spine procedures do increase the risk. The famous anterior cervical discectomy fusion, probably made famous as of late by Peyton Manning. This is the surgery that saved his career, went on to win another Super Bowl after being, I think he was kicked out of the Colts after having 3 surgeries. And he was trying all those fancy laser things and did a good old-fashioned ACDF, and power came back in his arm and pain was gone, and won a Super Bowl. So that procedure is done from the front of the neck, and you can get a lot of swelling and inflammation after the procedure to the point it starts to pinch the esophagus and causes increased pressure during swallowing. And if you do have your Killian's dehiscence region, your inferior pharyngeal constrictors are fibrotic and you're getting old and they're stiff, they can start forming a bump and a herniation. There's the ACDF, and this is how most discectomies are done, from the front. And yeah, they put a plate here, put a piece of bone from your hip in here, basically fuse the 2 disease segments together. There's a lot of things they can put. There's artificial disc they can put in there. There's all kinds of ways to do it, but it's probably one of the best spine surgeries that there is. Clinical findings. So again, you might be able to palpate that Boyce's sign. We talked about that already. So look for that between the thyroid cartilage and the SCM, about at the level of C6. The differential diagnosis are thyroid nodules, so we should talk a little bit about those. So you can get little bumps growing off your thyroid gland. In fact, they're found in about 3% of physical examination. You'll find these little bumps. On autopsy, you'll find them in 50% of people, so they're fairly common. And usually they're benign little fluid-filled cysts, no big deal. But about 10% of the time, they can be cancerous, and that's a big number, I think. Adults, 10% they're cancerous. And children, children should not have thyroid nodules. It's 25% chance of being cancerous. And they're completely asymptomatic, and that's a bad type of cancer to get. Usually it's caught when dysphagia and dysphonia occur, and that's not a good sign. Could cause chronic cough. I mean, that's when, if you're older, you have to go get this stuff checked out. Don't be an ostrich and stick your head in the dirt. Here's a picture of multiple thyroid nodules. Hopefully these are benign. Yeah, that's all I'll say about that. Back to Zenker's. So there's some complications. Usually there's no big deal. You just have to not eat giant swallows of food and you can live with it. About 1% of the time they can become cancerous, turn into squamous cell carcinoma, especially in smokers. Sometimes they ulcerate and perforate to the point where you can get bleeding into the esophagus and you might start spitting up blood, which is called hemoptysis again. It's coughing or spitting up blood. Not a pink frothy sputum, though remember that comes from the lungs, from pulmonary hypertension and pulmonary edema. Medications can cause these, like chronic use of aspirin. Oh, I don't think we came to that slide yet. We're in complications. Yeah, they can catch food. We already said they can cause a pneumonia, aspiration pneumonia. What's the treatment? Well, if you can't stand them, if they're large and they're causing trouble and you're getting pneumonia, they just go in there and sew them shut, basically. They cut out the excess and sew the esophagus together. And it's, from what I understand, it's fairly effective. It does require an overnight stay in the hospital. Surgery will usually be through the left side of the neck. They remove the hernia sac. Now, the complication is you don't know how much you're going to scar, just like with discectomy. You never know. I talked to a patient this morning, had discectomy. He did great with it, but he was upset because he didn't get 100% better. He had tiny, tiny scarring. Some people talked to a person 2 days ago, huge, massive scarring, surgery failed because he scarred up. Can never tell how much you're going to scar. But if you scar and that decreases the lumen of the esophagus, now you got yourself a beaver dam. Yay, we're done with the esophagus. Let's move on to the stomach. Now, I cut a bunch of slides out, so I just don't, there's so much pathology I can't get to. I just can't keep reviewing all your previous classes. But I have done it before, so I would strongly advise you, if you forgot the histology of the stomach, if you can't remember what an oxyntic gland is, what a parietal cell is, you should go look at this video. And yep, the video is called, there's the title, you can Google that, I'm sure it'll take you right to it. There's the link that you could type in. I know you can't click on it, but you can actually type it in. So I would strongly advise you to go watch that. You don't have to watch the whole thing because we're going to talk about some of it, but start it at 22 minutes and 35 seconds is where you start going into this stuff. I'll talk a tiny bit about it. I mean, here's the stomach. Remember, there's the stomach. It's right under the costal margins. And there's a space that goes through here. The lesser omentum lives behind this, or the lesser omentum covers the lesser sac, which lives behind here. Right, then there's a greater omentum that hangs off the bottom there, and it wraps around. And all right, that's about all I want to say about that. The regions of the stomach, it depends if you're in anatomy or in histology class. In anatomy, we have the fundus right here. We have the cardiac region is where the esophagus dumps into. The body is where all the rugae are. And the pyloric antrum, sometimes called the antral region, sometimes called the pyloric region. That's where the rugae start to peter out. And we have a very muscular pyloric canal here. And then we have the pyloric sphincter, which is much stronger than the lower esophageal sphincter. Now, if you're an anatomist and a pathologist, and it says GI pathology, so these are the regions as far as I'm concerned. Cardiac region, which is boring, it just secretes mucus. We don't care about this region. This is where the difference is. The fundic region actually contains the body of the stomach as well. Why in the world would they do that? What happened to the fundic and what happened to the fundus and the body? How come they're not split into two regions? Because they have the same cell type. So these all have fundic glands, aka oxyntic glands, live in the oxyntic region or the fundic region of the stomach. Pyloric region of the stomach is everything else. Those, guess what type of glands those contain? Pyloric glands. I left this slide in here, it's still confusing. So there's different types of glands, right? There's by the region. There's cardiac glands, there's fundic glands, there's pyloric glands. If you want to talk about them collectively, if you want to use all three of those, but just say one word for them, it's best to use the word stomach glands. So when I say stomach glands, it means I'm talking about all three, all of the glands of the stomach. The problem is some authors, including, I believe, let's see, who did that? Guyton, I believe, calls them gastric glands collectively. And he should not do that because some authors say gastric gland is an AKA for fundic glands, the ones that secrete acid and pepsinogen. So not good to call all of the glands gastric glands. I'd stay away from the word gastric glands, period. There's three types of stomach glands named by the area they live in. We already said this. Cardiac glands, really boring. Fundic glands are the star of the show, aka oxyntic gland, rare aka, a dumb aka, gastric gland. So watch out for that one. They contain the parietal and chief cells. Pyloric glands, they contain the G cells, which we'll get to when the time comes. And there's just to kind of remember your basic histology. This is the lumen of the stomach. The actual stomach gland has a kind of an entryway that's called the pit or the gastric pit. And these are mature foveolar or mucose cells, those are AKAs, that line the pit. The stem cells that give rise to them in the isthmic region. Then we have the body in the base. And this is where the magic happens. So we have parietal cells, which are secreting hydrochloric acid and intrinsic factor. Then we have chief cells, which nowadays it's politically incorrect to say chief because it's a reference to an Indian. So they're trying not to call it that anymore. They're trying to call it zymogen cells now instead. So I don't know what you're going to see on boards. Chief has been around forever, so I probably still going to be chief cells. They secrete pepsinogen, and then the mucose cells are in the pit here, in the gastric pit, and those are very important. Remember, those are the ones that release PGE2, and PGE2 comes back and stimulates autocrine, paracrine style, stimulates them to produce mucus and bicarbonate, and it stimulates, or the PGE also causes the shutdown of histamine by binding to ECL cells. And without histamine, the parietal cells aren't driven so hard. So it's another mechanism to kind of calm down the secretion of acid. All right, so that's enough. If you're completely lost on what I just said, I would go watch that video to catch up. Okay, NSAIDs and PGE2. Kind of just told you PGE2, so that's released again out the basolateral surface of mucose cells. And in order to release PGE2, you need an enzyme called cyclooxygenase. Usually it's cyclooxygenase 1 or Cox-1. Cox-2 can help, but not nearly as much as Cox-1. So Cox-1 creates PGE2, which of course is it's the enzyme that's responsible from your mucus coating around your stomach. That protects you from acid and protects you from aspirin and alcohol and straight shots and moonshine. That barrier is very, very important. Now, there's that two types of Cox. There's more. There's actually, I think, 5 types of Cox, but there's 2 that we care about, Cox-1 and Cox-2. Cox-1 is everywhere. It's almost every tissue of the body. It's also in the stomach mucose cells responsible for creating PGE2. And again, I just said this. I don't have to say that again. But Cox-2 is not quite as ubiquitous. It's in a lot of body tissues, musculoskeletal tissues, and such. But it's not in the mucose cells as much. So that's going to be an important point. But both Cox-1 and Cox-2 are really important when you injure tissue and you need to spark an inflammation to clean up that injured tissue. So, yeah, so they're both really important and involved in stimulating the process of inflammation. So we rip some ligaments in this guy, and that needs to be, they're bleeding, it rips so bad, and those ligaments need to be repaired or scarred over, and they need to be cleaned up. The dead tissue needs to be cleaned up, and that happens via the process of inflammation. And Cox-2 and Cox-1 are very important at starting that process of inflammation. Do you remember the cascade? I hope so, because I do love to test on it, and I'm not going to go over it because I know you've had it so much. But just as a refresher, remember when you have an injury, your membranes of your microcirculation, remember microcirculation is in all the tissue. So if you injure a tissue, there's microcirculation there. It releases phospholipids, and phospholipids come into contact with something called phospholipase A2 or PLA2. And there's other things. Angiotensin 2 can break down microcirculation endothelial cell membranes to release this dude, arachidonic acid. This is the first step of the inflammatory cascade. The breakdown, release of phospholipids from the microcirculation. the endothelial cell membrane via tissue injury, thrombin, bradykinin. I mean, the big ones for me, angiotensin II and tissue injury. So this is the first step. You need phospholipase A2, and this is the first step. You need inflammation, it's good for a while, but the body tends to way overdo inflammation, and it's helpful to shut it down later on. So it's good to let it run for a while. And then we can go two different ways. I won't talk about the LOX pathway and the leukotrienes, but the Cox, both Cox-1 and Cox-2, they convert arachidonic acid basically into PGH2, prostaglandin H2, via an intermediate. I mean, this is like POMC. It's really not super clinically important, but prostaglandin G2 is converted to prostaglandin H2. This one can go many different ways, and it has many different effects. So we're not going to thoroughly study them, but we're going to look at a couple of these, because right now we're talking about inflammation. So PGH2 can fight inflammation by calling in cytokines, calling in macrophage, gets the inflammation revved up, usually mostly by cytokines, and that calls in the troops. It can also go this way. Another enzyme can act called prostacyclin synthase can act on PGH2 and actually turn it into PGI2, or prostacyclin, which has anticoagulation properties. Well, that's awesome because we don't want blood clotting. All right, so that's great. So if you have an inflammation and you take Cox-1 inhibitors like NSAIDs, this is the step that it snuffs out the formation of inflammation. It turns off PGH2, so inflammation, the process, and it's a complicated process, but basically it shuts down PGH2 in a way that it can't go, and it inhibits inflammation. Because why would you do that? Inflammation is good. Well, inflammation is good for a while, but not for a long, long time. And so it gets out of control. You need to shut it off with Cox-1. In fact, Cox-2, like Celebrex, does exactly the same thing. So that's great. Now, here's some maybe not so great stuff. Oh, well, this is great stuff. Cox-1 will also inhibit the formation of thromboxane. Normally, early in the inflammatory process, you want some coagulation going on. If you have something bleeding, you want to stop that up. So Cox-1 turns that off. Cox-2, I guess, was I going to talk about this now? I'm talking about it, so let's do it anyway. PGH2 can also be blocked by Cox-2, but not Cox-1, and this is not a desirable effect. In fact, Vioxx was taken off the market because of this pathway. So Cox-2 interferes with the production of prostacyclin, which is one of the coagulation turner-offers. It thins the blood. And so therefore Cox-2 has the possibility to increase clotting. It lets this side of the pathway run wild. And that's exactly what happened with Vioxx. People were getting heart attacks and strokes because of blood clots, because of this pathway. And then it does other stuff too. PGH2 can be converted into PGE2, so that's important to us. PGE2, of course, is responsible for making and maintaining the gastric mucosal barrier. Cox-1 inhibits that, and there's where your stomach upset comes from the Cox-1 inhibitors like Advil and Aleve. Notice the Cox-2 doesn't do it as much. It can do it a little bit. Trust me, it can, because I've messed up my stomach from Cox-2 inhibitors. But I can't take Cox-1 inhibitors, period, or I'll immediately flare up my stomach. Cox-2, I'm probably good for a couple weeks before my stomach starts getting funky. Both Cox-1 and 2 via PGE2 also has effect on pain and fever. That both these cyclooxygenases can knock those out as well. All right, so that should have all been reviewed for you. And yep, the problem, as I've already said, is the COX enzymes hang around too long and they perpetuate the inflammation, which is great at first, but it's not good to keep that going for too long. It can start damaging good tissue. Therefore, you go to the doc if your chiropractic treatment isn't working, or you can, some multidisciplinary clinics use it in addition to chiropractic care. But you snuff out that inflammation after a certain point. And we talked about this. I kind of jumped ahead of my slides, but we have Cox-1 and Cox-2, kind of a good guy and a bad guy. I mean, they're both good guys in a way. Cox-1, again, those are the Advil and Aleve. We've already said all this stuff. But yeah, you used to actually need a prescription for ibuprofen and sodium naproxen and naproxen sodium. Either way you could say that. And now you don't. It's been quite a while without. So you have to be careful with these. You can hurt yourself if you don't ever take them more than it says on the bottle. And yep, so I mean, I don't want to go over that again. We just did Cox-1, but the key part of Cox-1 is this step. PGNE2 is blocked, so you can't fortify the gastric mucosal barrier. So that's no bueno. Okay, let's see. That's really, I mean, I've already talked about everything else. Cyclooxygenase 2 is better for inflammation. Well, it's better for, in a sense that you won't hurt your stomach. So Cox-2 doesn't affect the gastric mucosa as much as Cox-1. But there is some risk to taking them. Long-term use, they can affect, because they can affect the stomach. But the big one I want you to remember for Cox-2 is right here. So they stop the action of prostacyclin, and they stop the production. You need prostacyclin synthase to make prostacyclin. And without prostacyclin, you don't have any way to undo the coagulation that's going on over here. So this runs wild, and you have an increased chance of blood clots. And for whatever reason, the molecules are different. Celebrex seems to be doing much better than Vioxx. They're both Cox-2s. But really, Celebrex is the only one I would trust. Vioxx, I've had Vioxx. It worked fantastic. Probably better than Celebrex. Celebrex works better for me than NSAIDs. But this is worrisome here. All right, how do they work? NSAIDs are absorbed through the small intestine mainly. You should always take both of these, though. They are acidic based, so you should take these with food, both Cox-1 and Cox-2 inhibitors. Take with food because they can damage the gastric mucosal barrier. But yeah, so they are absorbed in the small intestine, they circulate in the blood, and they find that out of control inflammation and snuff it out. Okay, the problem is they snuff out your gastric mucosal barrier as well. So yep, the Cox-1 inhibitors knock out cyclooxygenase 1 in the gastric mucosa, and there goes your gastric mucosal barrier. Right, you have to have PGE2 production, but you can't if Cox-1 is inhibited by an NSAID. Got it? So specifically hinders the production of PGE2. So what? Well, again, as a review, PGE2 is really important. It comes out the mucous cells, out the basolateral surface, and it knocks out bicarbonate. It knocks out mucus release. I mean, these are two things that make the gastric mucosal barrier, and therefore it weakens the gastric mucosal barrier. And because it doesn't bind to ECL cells, remember PGE2 usually binds to ECL cells. Those are the ones that make histamine. It binds to them and stops the production of histamine. Histamine is the strongest driver of parietal cells. Remember, histamine binds to parietal cells and drives the production of acid. Well, that's not happening because you're not, PGE2 is messed up from the Cox-1 inhibitors. So therefore, your acid runs wild, you get an overproduction of acid, and you get an underproduction of the gastric mucosal barrier, and that's a recipe for disaster. So you can get GERD, ulcerative erosive esophagitis, gastropathies, which we'll talk about. You could get PUD, the peptic ulcer diseases, the whole 9 yards. There's someone with peptic ulcer disease, a nice, painful, nasty ulcer. And let's see, we're getting close to the pyloric valve in that person. All right, stomach glands, same deal. I used to teach these. There's a YouTube video on this. I would strongly advise you to go watch that because I assume you know that. I'm going to be testing you on that. So go watch that. There's the exact screenshot of the video. So go find that and go watch that. Again, we'll go over, well, I just did this. I don't need to keep this slide in here. But remember, again, the three main types of stomach glands. There's cardiac glands, fundic glands, pyloric glands. And we know the parts of the stomach already. The carotid glands, or the cardiac glands, do nothing. They secrete mucus. They're in the cardiac region of the stomach. The fundic glands are in the fundus and the body of the stomach is where fundic glands are. Pyloric glands are in the antral region of the stomach. Here's a oxyntic gland, parietal cells, and we got chief cells in here. Zymogen cells, I'm calling them chief cells. There's other important cells we'll talk about. That you remember the D cells. There's pyloric and fundic D cells that have a little different function, but those shut off parietal cells in different ways. Those are kind of the regulators of acid production. I always like this slide. That's a hipster. Google says that's a hipster. And we can use hip to tell us the three main juices that come out of a fundic gland or an oxyntic gland, aka. And those are hydrochloric acid, hip, intrinsic factor, those both come via the parietal cells, and then pepsinogen comes via the chief cells. So don't forget hip. I almost always ask that because I just like that. I don't know why. All right, this thing. So you've already had GI physiology, so you should know this already. So I took this out, but again, go watch that video if you're lost. But just a quick refresher. So you eat some food, you smell some food, think about food. It stimulates your brain. Your brain sends messages via cranial 9 and 10 to Meissner's plexus. Meissner's plexus will start with, it releases acetylcholine, ACH. Acetylcholine can stimulate the G cells in the antral region of the stomach to release gastrin. Gastrin is a hormone. Gastrin flows through the blood, and it's got a bunch of targets. The first target is it can directly bind to CCK2 receptors on parietal cells and directly stimulate the release of hydrochloric acid and intrinsic factor, which we could really care less about in, well, no, that's important. I shouldn't say care less about it. All right, but gastrin's not done. And we're in the interstitium now, right? The microcirculation has dumped out gastrin, and it's swimming, looking for cells in the interstitium. Well, it finds one, a parietal cell binds to it, HCl is released. It also swims over and finds an ECL cell and binds to the ECL cell, which stimulates the release of histamine. Histamine binds to the parietal cell, powerfully stimulates the release of hydrochloric acid and intrinsic factor. It also swims over and this is complicated because it depends how much gastrin. If there's a lot of gastrin, it can actually stimulate, because if you have tons of gastrin, it's assumed you have tons of hydrochloric acid. So it can stimulate the D cells to secrete somatostatin and actually shut down, the little negative means shut down parietal cells. But it has to be a lot of gastrin to do that. Because normally, if you're starting a meal, acetylcholine will bind to the D cell and it'll shut, and these are in the fundic region, because the D cells over here, it's a different story. But fundic D cells, the acetylcholine binds to them and shuts them down because somatostatin will shut down the parietal cell. And you certainly don't want to shut down the parietal cell when we're getting ready to digest a piece of steak or something. It's a high protein meal. So ACH turns this off. But it will be stimulated when gastrin levels get really high in the blood, although it's not a super powerful mechanism. as we will see. All right, so that is about the end of gastrin story. There's a GRP, gastrin-releasing peptide, that also comes from Meissner's plexus, does the same thing, binds to G cells, stimulates the release of gastrin to do those three things. Let's see, what else can we say about this? The antral D cells in the pyloric antrum, they're called antral D cells, they are acid sensors. They actually taste the lumen. They have little snake tongues that taste the lumen of the stomach, the pH. And they're asleep. But once the pH gets too low, I think I want to say about a pH of 3, they start to stimulate the D cell to release somatostatin. And somatostatin is a hormone, and it is a paracrine. It can swim over to G cells and shut them down and say, hey, okay, there's enough acid, it's time to shut off the acid production, so they can stop the production of gastrin, which drives acid production. They also go through the bloodstream. They end up in the fundic region of the stomach, and they shut down ECL cells here. They turn those off, and they can directly bind to parietal cells to shut it off as well. So that's the shut-off mechanism there. And I think I got everything I wanted to say. We could throw our mucose cell here in the gastric pits. So remember, they secrete PGA2. That goes over and inhibits ECL as well. That's not a very powerful mechanism. All right, so that was juicy stuff. If you're lost, go listen to that video. Zollinger-Ellison syndrome. I think I actually want to stop here. So yeah, let's stop right here. All right, we'll see you in part 2.
All right, let's talk about Zollinger-Ellison syndrome, get to some pathology now. So in this condition, the patient has developed a neuroendocrine tumor that usually lives in the pancreas, so it's ectopically secreting gastrin, right? Because gastrin comes from G cells in the pyloric region of the stomach, the pyloric glands specifically. And anytime we get a bunch of cells or glands secreting gastrin somewhere else, that word ectopic comes into play. And yeah, they can be in the duodenum as well, about 10% of the time, but it's usually the pancreas. So what? Who cares if we have extra gastrin? Well, gastrin's going to do its thing, and it's going to hit the parietal cell and stimulate it, directly bind to the parietal cell, and cause an overproduction of the parietal cell juices, which are hydrochloric acid and intrinsic factor. But it also binds to ECL cells, right, via CCK2 receptors as its binding receptor, and then it releases histamine. Histamine in turn binds to H2 receptors on parietal cells, so you get a double whammy, a double stimulus for the release of acid. So you get huge amounts of acid secretion in people with this problem. So huge amount, how do you say that in medical lingo? Hyperchlorhydria. Hyperchlorhydria is too much hydrochloric acid secretion. So these people are very prone to GERD, and worse, the acid actually rips up their stomach and intestine to the point they start getting ulcerations. So they get PUD, peptic ulcer disease. And yeah, and then all that acid actually dumps into the intestine, the small bowel, and causes trouble. Beside PUD, that's peptic ulcer disease is ulcers in the intestine, or usually in the duodenum, first part of the duodenum, and or in the stomach. But it also causes a pretty bad diarrhea because the acid irritates the lining of the intestine, specifically the enterocytes. And when they get irritated and inflamed, they don't work. And an important job is to absorb nutrients and water. And so therefore you get dehydrated with this as well. So histologically, if you take a sample of the parietal cells, if you take a sample of the antrum of the stomach, it'll be normal. But if you take it, because this is not a G cell problem in the stomach, it's a G cell problem in the pancreas or some other tumor somewhere else. But if you take a histological sample of the fundus, you'll see that the parietal cells are huge. They become hypertrophied. There's too many of them. It's that old saying, practice makes perfect. If they keep getting stimulated by gastrin unregulated, they get huge. The ECL cells also get huge because they're also, the things that bind gastrin are also huge. The authors they leave out fundic D cells, but that also can hypertrophy, even though they forget to mention that. I've seen that in papers. So, yeah. So what are the symptoms? Well, they're the symptoms of severe GERD, heartburn, right? They get heartburn. But they tends to be more stomach upset with these people, because some people, if you have a tight lower esophageal sphincter, maybe it's not that bad. But your stomach and your intestine can't handle that acid. So 75% of the people have dyspepsia from the acid, diarrhea, 75%, and 71% have flat-out ulcers, which in this day and age usually aren't dangerous. Usually they can be controlled. You could cauterize them if you need to. But I mean, back in the day, they're fatal. Again, the diarrhea, as we already said, the enterocytes get irritated and they don't work, and therefore water goes right through you and causes diarrhea. It's not really bad enough. Somebody asked once, well, I know diarrhea, that can cause a dehydration. It's usually not that bad, so you're not going to, because we know in dehydration, usually lose a lot of free water. So it doesn't cause a hypernatremia typically. But if the acid, the really low pH, also deactivates a very important enzyme that's released by the pancreas, and that's pancreatic lipase. We need that to break down fat so we can absorb the fat and get it into the bloodstream and get it out of the fecal material. But pancreatic lipase, it can't take that acid and it's destroyed. And so you get tons of fat in your loose stool, and that gives us something called steraturia. And pancreatic disease can also cause steraturia. Anything that messes with or doesn't produce pancreatic lipase, you get very fatty stool. Gross picture warning. There's patient with steraturia from ZE syndrome. You can see it doesn't have a diarrhea. It's a pretty loose stool, though. That's kind of the type of diarrhea they get. So what are some of the signs of this? Doing an endoscopic eval or a camera eval and you find ulcers in the jejunum, that's almost unheard of. So that's a sign of ZE syndrome. Or in the late distal duodenum, you usually don't have ulcers there. In normal run-of-the-mill acid-induced PUD, you get ulcers in that very proximal part of the duodenum, part 1. And weirdly about these tumors is they can go through cycles of secretion. They can go a couple months and then stop, and then go a couple months and stop. So one good thing, at least, you're not going to have H. pylori infections in these patients. It's too much acid, the oversecretion of acid, even H. pylori, which loves an acidic environment, it can't handle being in that type of environment. The classic 4, lots of stars, I think I've always asked this question. The classic 4 diagnostic findings of Zollinger-Ellison syndrome. Hypergastrinemia. You do some blood work and gastrin levels are really high. Then you can do a mammometry and test for acid. They have hyperchlorhydria. They are refractory to the regular treatment for PUD, and it keeps coming back. So you can't, usually you let an ulcer heal and it's done, and the patient knows not to do the things that cause it, like drink alcohol. But it keeps coming back for no reason. And then on histological evaluation, the parietal gland, the parietal cells and the ECL cells are really, really big. You can even see that visually too, because visually you could, with in the fundic region of the stomach, if the parietal cells get that big and the ECL cells both live in the fundic region of the stomach, they look huge. The rugae look huge. Look at these rugae. They're gigantic. So that's a patient with ZE syndrome. And differential diagnosis is a little scary diagnosis. Mentier's disease and lymphoma also can do the same thing, cause hypertrophy of those cells, which we won't discuss those mechanisms. Well, you treat it. How do you treat ZE syndrome? Just like GERD. So H2 blockers, which don't really do anything. Proton pump inhibitors is the big gun there, and then diet and lifestyle modifications. You got to eat 4 in the afternoon. Don't eat a heavy dinner. Make lunch your big meal of the day. And then find the tumor. Order a PET scan, a CT. PET scan's the best, but you look for it. You're going to have to search for that tumor. And if it's amenable surgically, maybe it's just in some weird muscle. Maybe it's in your psoas muscle. Maybe it's in an easy place where you can snip it out. If it's in the pancreas, it's a little hard to take out. It's a very delicate organ, but great if you can take it out. Remembering intrinsic factor. So we kind of covered this, didn't we? But it's part of the hipster, right? It's also secreted by the parietal cells. It's kind of when you hear parietal cell, you think acid secretion. You don't think intrinsic secretion, but it is secreted along with hydrochloric acid through the parietal cell. Its job is to bind with vitamin B12, which we're going to look at specifically here in a minute. And that minute is here. Let's look at vitamin B12. Let's talk about, I want you to know the structure. No, I don't do that. It's not biochemistry. Vitamin B12 is a water-soluble vitamin. Cobalamin is the AKA. It's found naturally in animal and dairy products and other sources as well, yeast and things like that. Its main function is you need vitamin B12 for the building process of DNA molecules. So when DNA polymerase needs it, it's needed in building the DNA molecule. It's also needed to build blood cells. So if it's dysfunctional, you get funky looking blood cells and you get immature blood cells, as we'll learn next week. And importantly to us, you need vitamin B12 to replenish the myelin sheath that is around all of your nerves, or all of your big important nerves, because myelin wears out and you have to replace it. And for that synthesis, you need vitamin B12. So guess what? If you don't have vitamin B12, your nerves lose their myelin and they start short-circuiting and acting weird, and that includes some of the pain fibers, so you can start getting some widespread pain via this vitamin B12 deficiency. It can't be made in adequate, the body can't make it. The bacteria in our gut can make a tiny bit, but it's certainly not even close enough to sustain life. It's only made really by bacteria, and algae are the ones that make it. And again, a little bit's made by the gut bacteria. Therefore, bottom line is we are 100% dependent on vitamin B12. We can't live without it. We have to eat it. And it's strange. This is really strange. Here's a great easy board question. It's a water-soluble vitamin. What's the fat-soluble vitamins? I always remember Deek. It's a guy. He's a chiropractor now. Son of an attorney. Deek, D-E-A-K. Those are the fat-soluble vitamins. They can be stored in the fat. You have to be careful not to take too much of that. But this is a water-soluble vitamin, which is usually urinated out, excess, but this one could be stored, and that's very strange. The foods super high in B12 are eggs, liver, shellfish, sardines, and a whole bunch more. So, in fact, the liver is so good at storing it, it can live there for a couple years. You can have a couple years supply of vitamin B12 stored in your liver. So that's kind of cool. Pure vegetarians, they have to get vitamin B12, by the way, and they won't eat eggs and all that stuff. They can get it from yeast and they can get it from other sources, but they have to be careful about developing a vitamin B12 deficiency. So this is the story I want you to know. It's how vitamin B12 gets into the blood. So first thing is we eat some egg or a piece of steak or whatever, something liver, something that has B12. So now we have a B12 molecule. B12 doesn't float around naturally. It's in food. It's attached to, we'll just call them food binding proteins. So these two are attached very strongly. You can't even chew these two apart. So you chew it up. That's called mastication, chewing. You chew it up in your mouth, and you're not going to break these two loose. These two are going to end up in your stomach, B12 and food binding proteins. But while you're chewing, I mean, that starts the whole the digestive process, right? The chewing, the sight, the taste, the smell, the chewing, that gets the enteric nervous system revved up, and you start releasing acetylcholine and get the acid starts flowing in your stomach. But it also stimulates the salivary glands to release some enzymes, and we have amylase and things like that. But the one that I like you to know is heptocorrin. Heptocorrin. It's also called R protein or R factor. Old books call it transcobalamin 1. Sometimes it's called heptocrim. It really should be called a holoheptocrin. This is the best term, but you're not going to see it. You'll probably be called heptocrin. Because there's actually an apoheptocrin that's secreted in breast milk. So, and yeah, so, but board books call it heptocrin. It's secreted from the salivary glands. It's a glycoprotein transport molecule, but it does not bind to B12 yet, but it sure will in a little while here. But it travels down with the B12 and food binding protein, travels down to the stomach where the next step of this happens. So swallowing, that's the act, that's called deglutition, as you'll know from physiology. And that's where the macerated food gets pushed back in your mouth and it triggers a reflex. The pharynx has a peristaltic wave that pushes it into the oral pharynx. I'm sorry, the oral pharynx that's where peristalsis starts. It pushes it down into the esophagus. And food binding protein plus B12 plus heptocorrin all go down into the stomach. Okay, food binding protein B12, you can see it still bound here heading down to the stomach. Heptocorrin released from the salivary glands like the parotid gland. All right, in the stomach what happens? Well, finally B12 gets broken, it's broken loose from the food binding protein. Who does that? Pepsin. Well, pepsin, who secretes pepsin? Well, those are the chief cells. They secrete pepsinogen, but pepsin, of course, is created by hydrochloric acid. So you need hydrochloric acid to make pepsin in order to break loose vitamin B12. Now, vitamin B12 is now naked and afraid, and it wouldn't last long in that acidic environment, but there's plenty of heptocorrin around, so it immediately jumps from the food binding protein to heptocorrin. Okay, let's see. Yeah, we talked about this. I think I have that slide. I don't need that, but there's the parietal cell making intrinsic factor. Okay, step 3. So now we have heptocorrin and vitamin B12. Heptocorrin can stand the acid environment of the stomach, and the two leave the stomach, are now in the small intestine. But intrinsic factor is also secreted. That, it doesn't do anything, it doesn't bind yet, but it's there and it goes out. So heptocorrin B12 are bound together, they're kicked out of the stomach. So is intrinsic factor. It's nearby, but it's not bound yet. So when heptocorrin comes in contact with pancreatic proteases, specifically trypsin, chymotrypsin, they will rip it right off. And so vitamin B12 is naked and afraid once again in the intestine. But not to fear, because now we have intrinsic factor near. Don't fear, intrinsic factor is near. I made a rhyme, didn't Yeah, and they bind immediately. And so from the duodenum, usually occurs in the duodenum, from the duodenum on down, intrinsic factor holds vitamin B12, and together they head toward the distal ileum. Remember the proteases. So there's one important one, just I could test you on, you never know. It's called enterokinase, aka enteropeptidase. It lives on the enterocytes on the brush border. It's not a free-floating enzyme. Trypsinogen is released from the pancreas. Chymotrypsinogen as well, released from the pancreas. And enterokinase will grab trypsinogen and create trypsin, the active form, which is a very strong, it cuts up proteins. But it also cuts heptocorrin loose from B12. If this is not working and heptocorrin stays with vitamin B12 all the way through the intestine, you'll have a vitamin B12 deficiency because it can't, heptocorrin cannot bind to the cells of the distal ileum. All right, only intrinsic factor can. So that's the story. Interestingly, once trypsin is made, it can actually go back and catalyze itself. It's autocatalytic to make more trypsin. Fun fact. All right, so there's where we are. So proteases, trypsin has been released here. It rips up heptocorrin, which is our green little thing here. It's loose, but never fear, because intrinsic factor is here. These two bind together. And now these two will go through the entire small bowel together until they come to the distal ileum. It's my favorite, kabam, like the cartoons I used to watch. And the real, it wasn't even a cartoon, that was the real Batman, and they would put these little graphics in there when he was fighting and go kabam. And that's exactly who the star of the show is. So kabam, they're more commonly called cubalin receptors, but a pretty strong AA is kabam receptors. There's a whole bunch of AKAs for these things. But these kabam receptors live on the simple columnar epithelial of the iliac cell, the iliac enterocytes, which are simple columnar. And they are able to bind intrinsic factor. And they bind intrinsic factor, who's still hanging on to B12, and it's taken inside the cell, swallowed by endocytosis. Then once inside the cell, it gets into the Death Star, the stomach of the cell. The lysosome grabs it and swallows it. And that is enough. I mean, there's wicked chemicals and all sorts of antioxidants and free radicals in lysosomes, horrible stuff in there. It destroys intrinsic factor and the cubalin receptor. But a miracle is somehow it knows not to destroy vitamin B12. There's the Death Star if you're a Star Watch fan. Watching The Mandalorian right now, I'm just really, even my wife is enjoying it, who doesn't like stuff like that usually, but what a great series if you haven't seen The Mandalorian. Can't wait for season 3. We're not done with season 2 yet, but anyway, there's lysosomes. And yeah, amazingly, B12 is not damaged. So next, B12 leaves the basolateral surface of the enterocyte and it enters the interstitium. So it goes right through the cell, spit out the bottom of the cell in the interstitium, and now it's naked and afraid again. And B12 doesn't like to be naked and afraid. So another transport molecule called transcobalamin 1. Remember the AK for heptocorrin was transcobalamin 1. I'm sorry. It binds to a different transcobalamin 2, which is made by the same cell that just swallowed intrinsic factor and B12. So they hold hands, and they go through the interstitium, are sucked into the distal capillary, and it ends up in the interstitial vein to the superior mesenteric artery. Remember this deal here, so it would be picked up here in the microcirculation. Well, it would be up higher, but here's the intestinal veins. Remember we saw those things coming off the superior mesenteric vein. And yeah, so it gets in the hepatic portal vein, and it's off. It's into the venous circulatory system through transcobalamin 2. So there it is. And it goes to the liver, the bone marrow nerves. Actually, it's going to has to pass through the liver next. So transcobalamin 2 and B12 enter the liver, where a lot of it is stored and absorbed, but some of it keeps right on going, and it's distributed mainly to the bone marrow and the nerves, because that's where myelin and replenishment is going on, and that's where hematopoiesis in the bone marrow is going on. So this is a perfect setup for us to talk about pernicious anemia, which is coming soon. Is there another way to get B12 into the bloodstream? Well, yeah, you can take B12 injections. In fact, that's the treatment for pernicious anemia. But even before you develop full-blown pernicious anemia, about 1% of vitamin B12 can be absorbed through any enterocyte, just through the brush border. It's not enough to sustain life, but if you megadose vitamin B12 when you're heading toward pernicious anemia in the early stages, you can stay away from the shots by superdosing or megadosing vitamin B12 under supervision of a doctor, right, though, because it's not fat soluble, but it can accumulate in the liver. But ultimately, you're going to end up having intramuscular injections, and then you're fine, except you got to poke yourself all the time. All right, let's hope this recorded. Somebody let me know if it didn't. See y'all later.